Good time. In this video, we'll talk about disease of aorta, namely aortic dissection, aneurysm, and some congenitals. First of all, it's important to know that aorta is divided into many parts according to its course through the body. Namely, it is ascending aorta, arch, descending thoracic aorta, descending abdominal aorta. First three parts are located in the chest, while the last descending abdominal aorta is located in the abdomen. Aortic dissection. Previously, it has been known as acute coronary syndrome. That's because the penis fell through the chest. But nowadays, it is known to be acute aortic syndrome. That's because the cause of the pain is from the aortic dissection. Acute aortic syndrome includes aortic dissection, penetrating aortic ulcer, and intramural hematoma. Epidemiology. The incidence is 2 to 7 per 100,000 of the population. Men to women ratio is 2 to 1. It occurs in winter seasons or months rather than in summer months, occurring in the morning more than evening, affecting descending thoracic aorta or abdominal aorta rather than affecting ascending aorta. Pathophysiology. Aortic dissection is usually associated with long-standing systemic hypertension, congenital abnormalities like congenital bicuspid aortic valve or coarctation of the aorta, genetics like Ehlers-Danlos syndrome, Marfan syndrome, or it might be associated or acquired from the tobacco use. Histologically, elastin fragmentation or the loss of elasticity. Mechanically, the artery or the aorta become more stiff and less elastic. Risk factors: chronic uncontrolled hypertension, gender difference, genetics, congenital abnormalities, age, as it occurs in late 40s to 60s in male and in 70s in female. On the other hand, pregnancy is also regarded as one of the risk factors for the aortic dissection. Clinical presentation. Actually, the aortic dissection presented with pain, whether it's felt in the chest, anterior chest, or in the back. The site of the dissection determines the pain location. If it is felt in the anterior chest wall, it is most likely ascending aortic dissection. While if it is felt as a back pain, it is most likely from descending thoracic aorta or descending abdominal aortic dissection. There might be some cases where the dissection of the aorta is painless, but when it is painless, the mortality is higher. Regarding types of the aortic dissection, majority of the type B, especially when it is chronic, is usually painless. But progressive enlargement of the false aneurysm of the aortic dissection might have some pressure effect on the surrounding structures as they course between them, like chest pain, dysphagia, dyspnea, wheeze, stridor, and else. On clinical examination, the patient might have hypertension or hypotension, or there might be differential blood pressure in the extremities. New murmur of the aortic insufficiency might be present. Classification of aortic dissection. Anatomically, it has been classified according to two systems in general, which they are Stanford and Debicki classification. First, Stanford classification, which is classified into A and B. Simply, Stanford type A refers to the dissection which might happen or occur anywhere in the aorta, while Stanford type B is the dissection confined below the arch, which means it will not involve the ascending aorta. But Stanford type A denotes that involvement of the ascending aorta or the entry point could be from anywhere in the aorta. Debicki classification is more easier and simplified. It is classified into type 1, 2, 3. Type 1 involves the arch. Type 2 involves the ascending. Type 3 involves the descending aorta. The type 3 is subdivided into type 3A, which involves dissection till the diaphragm, or Type 3B, which involves the dissection below the diaphragm. Diagnosis of aortic dissection. Biomarkers might be useful in detecting the early dissection. ECG is non-specific. It means that when you face a patient with a chest pain and you will do an ECG, you will find nothing related to the heart. That's because the pain is referred from aortic dissection. Aortography previously was one of the key diagnostic tools, but nowadays it's not widely used. Chest CT scan is a perfect diagnostic tool for such a condition and gives you an important anatomical subtraction of the tissues to know exactly where the aneurysm and where the entry point. Other diagnostic tools include transesophageal echo to exclude other sources of the pain. MRI is regarded as confirmatory diagnostic test, but nowadays not widely used. That's because it is costly and time-consuming. Actually, when you diagnose an aortic dissection, you will be able to notice that whether it is acute, subacute, or chronic. Acute occurs in 24 to 72 hours, while subacute occurs for 2 weeks. On the other hand, chronic aortic dissection when it occurs for more than 14 days. Treatment of aortic dissection. It depends on the location of the dissection, severity or acuity of the dissection, plus the complication of aortic dissection. Regarding medical treatment of aortic dissection is actually to change or divert the patient from acute to subacute situation or stabilize the patient in another meaning. That's by the use of anti-pulse drugs or antihypertensive drugs like trimethophan, reserpine, guanethidine. Surgical treatment is the best choice by resecting the involved part of the dissection and occluding the entry point. And now aortic occlusive disease is one of the types of peripheral arterial disease, and it is also known as aortoiliac occlusive disease. That's because it occurs only below the renal arteries, involving the iliac arteries. The occlusion might be due to atherosclerotic artery, thrombus formation, or emboli. Risk factors for aortic occlusive disease include tobacco, alcohol use, gender difference, diabetes, hypertension, obesity, lack of exercise. There are some of the risk factors for the aortoocclusive disease which they cannot be changed or modified, like age, gender, family history. Clinical presentation of aortoocclusive disease include Lyric triad, which includes claudication of calf muscle, unilateral or bilateral, absent femoral pulse, impotence. Diagnosis and evaluation. First, lab tests, which include HbA1c for the diabetic cases and the lipid profile for all cases. Ankle brachial index, which might be below 0.9 or below 1. Duplex ultrasound gives you an important clue about the state of the arteries and the occlusion site. Magnetic resonance angiogram. Most of the cases requires coronary angiography to exclude coronary involvement by the same process. Classification of aortoocclusive disease include type 1, 2, 3. Type 1 when it is involving the aorta till the common iliac arteries. Type 2 when it involves the common iliac and external iliac arteries. Type 3 when it involves the femoral popliteal artery. Non-interventional treatment of aortoocclusive disease include modification of the reversible risk factors, which they can be changed, like cessation of smoking, dietary habits, regular exercise, plus some of the medications that are necessary as a treatment of aortoocclusive disease, like antiplatelets, statins. Indications of surgical management includes limitation of the lifestyle, rest pain, plus when there is tissue loss due to ischemia. Surgical options include thromboendarterectomy, aortobifemoral bypass, extra-anatomical bypass, or percutaneous intervention. Aortoiliac thromboendarterectomy, The advantage of this procedure is that you will not put any prosthetic device inside the abdomen, especially when the abdomen is hostile, or in patients with diabetes to prevent infection, which is regarded as foreign body. The contraindication of that is when it is for a longer segment involvement and there is some degree of degenerative aneurysm of the wall. Aortofemoral bypass, especially when it is bilateral, it is done through the median laparotomy and inguinal incisions. Postoperative medications include heparin and aspirin. Extra-anatomical bypass grafting means tunneling of the subcutaneous tissue to get a blood supply to the lower limb from a blood supply or artery in the upper limb. Types include axillofemoral bypass or axillobifemoral bypass or femoral bypass. Major indications of extra-anatomical bypass include when the patient has another comorbidity that mandates you to do simpler operation rather than that big risky operation. Those comorbidities include renal impairment, severe uncontrolled diabetes, or weak patient, CVA or cerebrovascular accident. Or there might be hostile abdomen, like infection, presence of stoma in the abdominal wall, previous surgery, fibrosis, morbid obesity, congenital abnormalities of the aorta. This includes patent ductus arteriosus, coarctation, aortopulmonary window, truncus arteriosus, vascular rings. Vascular rings are not common, nearly 1% of congenital heart diseases. Although there are vascular abnormality, but the symptoms related to other structures which they are compressed by these abnormalities. The two major types of vascular rings are double aortic arch or right aortic arch with the left ligamentum arteriosum. Classification of vascular ring include complete vascular rings or incomplete vascular rings, or pulmonary artery sling. And now aortopulmonary window. It is the communication between the ascending aorta and the pulmonary trunk or right pulmonary artery. But the difference of this aortopulmonary window from the truncus arteriosus is the presence of well-defined and separated apparatus of aortic valve and pulmonary valve for each. The Mori classification of aortopulmonary window is type 1, 2, and 3. In type 1, near to the valve, there is communication. In type 2, away from the valve, there's absence of the aortopulmonary septum or the communication. In type 3, there is complete absence of proximal and distal part of the septum. Truncus arteriosus. This is exactly the same as aortopulmonary window, but there's a difference between these two clinical presentation. As in truncus arteriosus, there is no separate apparatus. Truncus arteriosus is also a rare condition, which occurs in nearly 0.5 to 1%. Truncal valve is composed of 3 to 5 cuspes. Magnetic resonance angiography is the diagnostic and differentiative tool to differentiate between aortopulmonary window and truncus arteriosus. And now, aortic aneurysm. Aortic aneurysm classified according to many ways. One of them is morphological, or the shape of the aneurysm. Whether it is involving the whole circumferential part of the artery, it is called fusiform. While if it is saccular with having a neck connected to the vessel, there is again classification according to the location, which means that probably you will say or you'll hear about ascending aneurysm, arch aneurysm, descending thoracic, descending abdominal aneurysm in general. There are other classifications like etiological classification, although it is difficult to detect the causative factor for the aneurysm that occurred in the aorta. That's because it is multifactorial in general. Anyway, there might be a list of etiological factors for the aortic aneurysm. like median degeneration. It might be idiopathic without any cause or without any explanation, or it might be related to congenital abnormalities, like Ehlers-Danlos syndrome, Marfan syndrome, or else. Infection is another cause or etiology for the aortic aneurysm. Or the wall is inflammatory, like tachyarthros or other inflammatory disease of the vessels. Clinical presentation of aortic aneurysm, it might be asymptomatic and incidentally found on chest X-ray for other purposes taken. Or there might be pressure effect symptoms to the nearby structures when it enlarges. But the commonest presentation, when it is related directly to the aortic aneurysm, is the chest pain, or the pain at the site of the aneurysm, as far as there is impending rupture or increasing in size, stretching. Diagnostic methods. First of all, the clinical presentation, and then imaging techniques like chest X-ray, CT scan, MRI, or MR angiography. The incidental diagnosis of aortic aneurysm occurs when you take a chest X-ray for a patient for another reason. Medical treatment of aortic aneurysm includes the way to prevent increasing size of the aortic aneurysm. In general, avoid exercises like weightlifting and heavy exercises elsewhere, or heavy occupations even. And drugs which they are used in the treatment of aortic aneurysm includes anti-impulse and antihypertensive drugs. Non-elective, which means emergency indication for surgical treatment of aortic aneurysm, includes when it is severely symptomatic or acutely symptomatic, plus the size of the aortic aneurysm is more than 4.5 centimeters to 5 centimeters. Or if it is associated with congestive heart failure, it should be treated surgically as soon as possible. On the other hand, when it is asymptomatic, but it is 5.5 centimeters, it should be operated. Or if you face a patient and follow him up, and you find out that there is 1 centimeter increase in the size in relation to the previous year size, so you will do surgery for that patient, which means that any increase in the aneurysm more than 1 centimeter per year, that's a strong indication for the surgery, because it might rupture at any time.